and welcome to our webinar today. I'm Kathy Susich from Dimensional Insight, and in a moment I'll be handing it off to Nora Lissy to present. We'll keep this short today and under 30 minutes. If you have questions for Nora as we go along, please enter them in the GoToWebinar panel and we'll save some time to answer a few questions at the end. Our presenter, Nora Lissy, is Director of Healthcare at Dimensional Insight. As a former ED nurse, Nora brings her clinical and data experience to her work in helping Dimensional Insight customers implement the processes and technology to gain the most impactful insights that get results for their organizations. Nora will talk today about some common challenges staff in the emergency department face and how analytics can help solve these challenges. Nora, the floor is yours.
Okay, thank you, Kathy. I hope everyone can hear me. As Kathy mentioned, we're going to go through how do we use data and analytics in the ED to help us kind of keep it smooth flowing and operational. Okay, if I can click my mouse, I'll be all right. There we go. There we go. So the biggest question comes out there all the time is, do you even trust your data? No matter what ER I talk to, even when I was a clinician, and you talk to either the finance people, they have a number of visits and things that happen in there, and then you have the folks who are operationally in there doing things, and they don't always necessarily believe the numbers that are coming out of the reports and in the back end. So, you know, first off, we've all got to get on the same page as to what is a number, what are we looking for, and what is a true metric we're measuring. Why is performance important? Obviously, it's extremely important because the ED essentially is the main portal of entry into your healthcare system. Yes, you have ambulatory, you have direct admits, but a good portion of the in-house patients come through the emergency room. With that, if you have a lack of efficiency in the emergency care center, it's going to negatively impact everything else within the organization, not just in the emergency room itself. Wait times will increase. They'll also increase your length of stay, leaving without being seen and reducing, obviously, your chance for revenue. Poor throughput also leads to poorer quality of care, and it also could lead to overstaffing, which will then increase your costs. Some of the common emergency department performance issues are high LWBS rates, hence there's a national measure about that. Decreased revenues due to lost charges, patients leaving, so on and so forth. Decrease in hospital admissions, poor hospital reputation, lower patient satisfaction, poor outcomes, increase in diversions, decreased staff satisfaction, and increased risk for error. Obviously, these are things that could happen if you have poor performance, but most hospitals are striving to have the higher performance, and we're going to talk to how you do that. Factors that influence the throughput come from both internal and external factors. Patient arrival times could actually be more of an external factor if you think about it, because you can't control when patients decide they're sick and they're going to go to the emergency room. So it's really an external factor that affects how things happen inside. Staffing, do you have enough staff to cover even the emergency beds that you have, let alone if you get a surge of patients? The capacity of the ED, how big is the ED compared to your volume? I mean, I've worked in EDs as little as 7 beds and as high as 127 beds. And, you know, either depending on the bed size really makes a difference as to whether you can handle the capacity. And then the workflow. You know, do you have certain areas set aside for your complex patients, and not just fast tracks, but maybe the ones that can go through the system, but you know they're going to be waiting for lab results and so on and so forth. Can they be put in an area of the ED that's not going to cause capacity flow back up on you in other areas? Some external factors such as no other hospitals in the region. A lot of that can happen. The hospital's at capacity. If there's no floor beds available, then those patients have to board in the ED. And there's nothing worse for an ED nurse. I'm an ED nurse, I'm not a floor nurse. And then you end up having things that happen there. It's a totally different mindset taking care of a floor nurse than it is taking a floor patient versus an ED patient. And then also when a hospital's at capacity, so are all the other departments. So therefore it's taking longer to get labs, it's taking longer to get the CTs done, so on and so forth. So it really is the pivotal point in the ED is to keep that moving quickly. But this has to be an interdisciplinary process. It can't be just the ED sides. They want to be better, and therefore we say we're doing this, and everybody else can, works. We have to do this all together. So how do we go about this? What's our start? Like I said, first we must start with an interdisciplinary process where we are including folks from lab, radiology, environmental services, all the ancillary areas that the ER is dependent upon. And we have to have them involved in the process, but also looking at the various timestamps that happen to a patient. Is there, an organization might feel, well, we're doing pretty good. Our length of stay in the ED is only 4 hours, but maybe you can make it 2.5 if we improve some of the processes in between. So we're looking at what is our process when the person walks in the door? Do they sign a piece of paper? Do they get greeted by somebody? How quickly are they registered? And then once they have that quick reg number, do they go to triage, and then how quickly is the process from triage to getting their first registration chart so that they can go to the back and be treated? And then how long is it before they go into the room that a provider sees them? We also want to know what are our starting rates. So when we embark on this process, what was our left without being seen rate when we started, our AMA rate? What are our timestamps, our arrival to decision to admit, our arrival to departure? Where are we standing now, so that as we continue to make improvements in our process, we have something to compare against? Oftentimes, organizations will embark on a process improvement and kind of forget to mark those beginning numbers, and then you're kind of trying to figure out where you were at the start. Okay. Factors that influence throughput. So what are some of the solutions based on the data points and the data that you gather can we put in place, such as, redesigning the registration area so that you improve efficiency and patient privacy, adding an advanced level practitioner to the triage area so that when a patient comes in, the ever nebulous abdominal pain, but you're going to order labs, you're probably going to order either an abdominal pain x-ray or some kind of x-rays. If they can get that and assess that patient and triage and get that order from the start, that there's time for those to get processed through and everything, so it'll help to move that process along. Better use of the ED rooms, as I spoke to earlier about, perhaps these patients that they're not necessarily, critical but they have labs and they're pending. Can we put them in an area where they're not going to take beds away from other patients once we've done all the work we need to do with them? Adjusting staff levels to meet the demands by volumes through ED forecasting. So can we predict, based on the current ED length of stay, how many beds we need to have open and how many staff we need to accommodate that? So what is our process there? And so we can build a prediction model for that. Also, using hourly census and volume prediction, you can begin to identify surges sooner. So when you start to see the numbers ramping up, you can call the staffing office or call your staff in and say, you know what, I need you to come in at 1 today instead of 3 because we're slammed and we got more coming in the door. It's what you typically do now, but it's being able to kind of be ahead of that and get further down the road with that, if you will. But you need the data to know where to focus. So in Dimensional Insights ED Advisor, this is our step into starting to go into the waters of looking at ED data and what we can use, how we could use it to improve our processes. We provide some analytical dashboards, mobile analytics, and also some advanced analytics, like I said, looking at forecasting volumes and what you can do. And I'll give you an example from a forecast perspective. When in an ER that I worked in, which was 127 bed ER, obviously you're not going to staff that ER at 7 o'clock in the morning, all 127 beds. And you're not going to do it at 3 in the morning either, but you're going to have your flow. And we were able to implement a forecasting model that looked, and we refreshed it every hour. So you saw how the volume was coming in the door, and you saw how the current length of stay was for those ED patients. And then that helped to drive whether we needed to bring in more staff or open up another pod or bring more rooms and more beds into play. So, and it was pretty helpful. We did a similar thing on the in-house. When I talk about disciplinary, they did a similar thing up on the patient staffing area, and the beds are, so that they would know when there were beds becoming available and how to predict when they were going to need, because that incorporated the surgeries, because sometimes ED patients can't get to the floor because there are surgeries ahead of it. So when you bring all that into play, you can better map out your day and do your staffing and planning to make it a more smoother transition. I'm going to take you into right now. I'm going to take you to our once I get my. I'm going to take you to our demo now. This is the emergency department advisor, and this is what I would say, this is our starter into emergency medicine. We have, and the reason why I say starter is because we have done this at several customers, and then they take it and run with it when they come up with, one of the nice things about this process here is that it's very flexible and customizable. So I've got customers that are adding their risk scores for going into diversion by using the EDOC measures and bringing different information in so that they can actually tie that into what's going on the floor. They bring in information from their hospitalists and they try to match that up to different information. So this is just the starting out of the box, what you would do as a beginning journey into the ED analytics, if you will. In this, we have the various measures that I'm going to talk about. The technology behind this ED advisor is we bring information, we give you the source of truth. When you look at any measure, you will always know the definition of that measure and what you're looking at. So when you're doing these KPI developments and looking at what your measures are, and you determine what the definition of a measure is, people agreed upon it, you now have it. And when I want to say, for instance, what's an ED visit, right? People, depending on who you talk to, is an ED visit one that's billed? Or is an ED visit also the patient that came back for a recheck, or a patient that, you know, depending on where my ED is, some, you know, critical access hospitals, those EDs are also used to do blood pressure checks. And so where do you count your numbers and how do they do it? So you could actually do this in the ED visits here. I'm going to show you an example where I could click on a measure overview and I'm telling you, and so here's my definition, the number of accounts with at least one ED encounter by arrival date. We're going into the ED log, so each EMR system has a log specific to the ED. We'll go in there as long as it's a valid account and they've got an encounter in there for an arrival date, then they will be counted in there as a visit. I can look at my visits by, I can talk about if I wanted to filter it, maybe I'm looking at it by a specific type of visit. Maybe we want to exclude, we look at the ED log, but exclude those that are assigned to urgent care or something to that nature. You will see all that written out in your definition over here. On the right-hand side, we can take a look at different things such as by a standard calendar or by my fiscal calendar. How do my volumes look year to date? Maybe I want to look at a rolling 12 months instead because it's the beginning of a new year, and so I don't have a whole lot of data for this year, but I want to look at the last 12 months. How am I trending? I could take a look at that. I could hover over any of my little dots here, and it's going to tell me what my volumes are comparatively. Maybe I want to look at how this current month is going. I could switch over here and see. So my current week is declining over the previous week. So maybe that's good, maybe that's bad. We can see what's happening, but you kind of see how your volumes are flowing through. I could also do some further analysis in here where I can begin to dive down and look at potential reasons for what's going on. I'll look at my volume. So here I'm looking at, I have 4 different facilities in my demo data here. Maybe I'm from Springfield Hospital and I want to look at, this is demo data, so it's in 2018. I want to look at just 2018 alone by itself. And maybe I don't want to look at it by ED volume. I want to look at it by ED provider. So I can come over here and I can find my ED provider. And now I can see by doc who saw the patients. So Dr. Schwartz has seen the most patients, but it's 12% of the total volume. He admitted 298 of them. And he had 64 observation patients and he discharged 1,417 of them. I could also come in here and go, well, what kind of patients is he seeing? Like, what's the chief complaint of those patients? So I can click on the chief complaint and I see abdominal pain, that wonderful abdominal pain, it takes forever, here. And I can actually, and if I wanted to, I can get all the way down to what was their ED disposition. So there were 102 of them were discharged. These inpatients were here. So now I can go, okay, so who was the attending doctor on those patients? And you see how I can keep on diving into my data to look down and see, I'm looking at Dr. Schwartz, abdominal pain, the patients that he admitted, these are the attendings that admitted his patients, and so on and so forth. So that I can kind of dive through this and continue to dive down. If I wanted to bring this information to him for a report and say, hey, let's take a look at what's going on, I can drop things into an Excel file if I want to, or I can drop them into PDF. I can also, and I'm not going to extend it here, but I can take them into, we have a FAT client that allows you to do some either further analytics that are off of a dashboard that allows you to do some other calculations. I'm going to take you through those. These are the measures that come out of the standard deliverable. We have we break out ED visits by admitted, departed, those that discharged observation, those that transferred to psych, and then we have all the other breakouts that we put in there. You know, those that went to the OR, those got transferred to another acute care facility or got transferred to rehab. And down here you have, this is your ESI level. So this is what the triage level was compared to what the actual build level was. So how close are we, even though they kind of go in different angles, which, you know, how close are we with what we triaged them as and what they got billed out as. We have your outcomes. We begin to look at those patients and see who's coming back in 48 hours, who's coming back in 72 hours. Is it so these are my 48-hour indices with return. I could click on that measure. I come up here, it's telling me what I'm looking at. So in our measure here, we're only including ED patients that actually go out the door. So if that patient either, you know, obviously if the patient died, they can't come back again, but if they discharged against medical advice or they got transferred to another facility, or they got admitted to the hospital, they're no longer an ED patient, if you will. That would be an ED responsibility as to why they came back. And then you can go into this data here. So I can go into this analysis here, and I can, again, maybe I want to do it by doc, and I want to see the ED provider. And who has the most, well, Dr. Schwartz had the most patients, so it makes sense that he might have the most ED returns. But I can then actually come down in here and I can see, you know, what are the chief complaints of his ED returns? And we could actually do this by the previous, I can look at the previous ED, I don't have that on here, I was gonna say. I don't have it. But I can look at who the previous ED provider was. So Schwartz he's the one that had the most ED patients, but I can say what was the previous ED principal diagnosis. That's what I was looking for. So 10 of them haven't been coded yet. So that could have been in the last month, and I can take a look at that and confirm that by looking at their ED departure date. So now I'm looking, okay, and I'm looking at 18, right? Because that's what my demo data is. So I'm making the assumption right now that these patients just haven't finished being coded yet. So I don't know what their principal diagnosis was. But then the others, I could actually do that and go down to it and see. I can also see if you have a multi-facility hospital, you can see what facility were they in before they came here. So did they come from this facility, or were they at the other campus and now they're coming to this ED? We can begin to look at those analyses. Over here, we've got the mortality. Then you've got your different types of departures, AMA, LWBS, and eloped. You have the boarding measures. So how long are the patients staying in the ED? You know, so once we've made a decision, how long are we keeping them? What's our boarding times? Are we getting them upstairs within an hour, or are they staying another 4 or 6 hours, so on and so forth? How long is it taking us to make a decision to admit? Over here we have, again, this is more related to the boarding. So we have the boarding patients, and the definition, I'm going to take this out before I try to do it by memory. The number of ED patients that are boarding include admitted patients, those under observation by arrival date. We need to, basically what this is anybody that's, a decision has been made to stay in the ED, they automatically are, the decisions are made of their outcomes. They are now, from a CMS perspective, they're a boarder. They become excessive boarding when they're over 4 hours. So in our definitions here. And again, these are definitions that we come up with that certainly are multiple, that can be changed by the end user, by the organization that puts it in place. We look at the charge activity. How many times do we have? I know that in my previous life as an ER nurse manager, oftentimes we were trying to reconcile charges against actual patients we saw versus did we post the charges. We actually bring this in for you so you can see it right away on the next day that charges have not been posted, and can stay on top of that. And again, you'll notice every page I go to, the functionality is pretty much the same. I can change to whatever dimensions I want. These dimensions are dimensions that are related to ED and or account information, so it would make sense that you can come through here and look at them. These are all customizable as well. On the visit level side, again, like I said, this is really more of the level of care that is at the CPT level versus this is the triage level. And then you have information. We bring in the ED census hourly. And what's critical about that is that's where you really can get a hold of, build in some metrics around, what you're trying to accomplish when we bring in the ED census. And perhaps you're going to bring in information about the hospice when they were, what was the time that the patient had a decision to admit, the hospice was paged. What's the time between the decision to admit and the hospitalist responding and really assessing the patient and writing the orders. You can bring in all these different timestamps along with this, and you'll have this all added and enhanced. Additionally, we have turnaround times. So these are the critical ones that we're talking about that really affect your patient flow. So when a patient comes in the door, what are our timestamps? I come in the door, am I greeted by somebody? Do I go to the registration desk and sign my name on a piece of paper and sit down in the chair? And when someone in triage has a chance, they call my name out and I come up? Or is there someone that officially takes me, gives my card to somebody, gets me started? We look at that time, then once that process is started, when do I go to triage, so on and so forth. But we also bring in information around what are the key things that tend to be backlogs in the ER. Ordering of x-rays and imaging studies, CTs, ultrasounds. How long is it taking us from order to the test being done to the result being received, and then the patient then being dispositioned? What about lab information? Depending on the lab work, if you're going to get a CBC, that's going to turn around a lot quicker than a CMP. So what are our turnaround times for our different labs that we're looking for? And then you can also then, because we're bringing in your orders and you're bringing in the labs that are being ordered, now you can do further analysis on, the disease and the final diagnosis, and what's the lab work we're ordering? Do we really need to be ordering these, the CPK on this chest pain anymore? Is that part of our standard? So you can begin to analyze what you're doing from an ordering standpoint, and is it really efficient, and was it necessary? And again, then we just look at just generic turnaround times for anybody that has had a lab. How long is it on general? How long is it taking for all their lab results to return and be available to you? So here, the average order to, and so the average ED time to order, 76 minutes. That's an hour. That's an hour that's taken. That's the time in minutes between the arrival in ED to the individual order that's placed. So is an hour a reasonable time to place an order? Probably not. You could probably tighten that up a little bit. So those are the kind of things that you can look at. Again, depending on what the order is and how fast the patient gets there. But I could dive into here. I could look at my chief complaints. I could look at back problem. Maybe you want to see order category. Are there any orders on those patients? So there's imaging. It's taken 410 minutes for the order to come in. Is that because the patient, it took that long to be seen by a physician, or it took that long for things to come through? So that's where you get that data and that information to be able to look at those and analyze what's going on to help, again, improve your processes. So that's the measures that are in all these different dashboards. I'm going to take you through a couple of the pages just to kind of give you a flavor of how those are used in a dashboard perspective. What I was showing you on that one page was just basically what I call the table of contents, or the list of measures, the types of measures that you might want to be measuring when you're trying to do some process improvement in the ED. We'll look at the ED visit throughput. And I apologize because my internet is a shared internet with other people in the community, and it seems to be slow. So here we're looking at those measures that I showed you on that dictionary page, and they're kind of segmented out now. So we're looking at visit level turnaround time, segment turnaround time, So this is like the overall, and then I'm looking at the different segments. So ED arrival to triage. The average is 53 minutes. That's probably a little too long. You might want to get that down a little bit so you can begin to analyze that. And then on the right-hand side, you'll notice that these are little chevrons showing you, how am I compared to last year? So I'm looking at month to date, current complete month, and year to date. It's allowing me to do some time comparisons and see how am I doing? Am I getting worse? Am I getting better? And if I'm not, if I'm getting worse, what are some of the things I can now start to look at? So for instance, in the ED arrival to provider average, it's down by 7%. So we're showing some improvement there now. So we kind of look at that and look at the various measures. Same thing with the ED boarding. So the ED boarding hours are down 214 hours compared to 331 the prior year. Is that, but still, is that satisfactory? Do I want to get better than that? So now I have the information to do here. When I dive on a number, it's going to pop up a similar analysis that you saw, but now what you see differently here is that I'm actually seeing my comparison, and I maintain that comparison all along, no matter how I change my dive. So I'm looking at chief complaint here, but again, maybe I want to look at it by ED provider. Instead, I can come right here to ED provider, and now I'm seeing Dr. Golden this June compared to last June, so on and so forth. And maybe I want to look at it by, I don't know, financial class. What's my makeup of volume in the ED based on financial class? So I can continue to dive. You see that same spirit all the way through, is that the dive is literally, if I show a finger, I can dive. If I dive on my definition, I'm going to get if I dive on my measure name, I'm going to get a definition of what that is. I'm looking at ED obs length of stay average. That's the average lifetime in minutes between arrival to departure, and for ED visits that discharge from observation by arrival date. The key to this measure here is that they had to have been discharged from the ED as an observation patient, and because oftentimes you'll place them up on the floor, and when they got discharged from the hospital off the floor, they were still in observation status. Because as we all know, sometimes a patient may get in as obs and then the next day they're converted to an inpatient. That person would not be part of this metric. That person is part of the metric of patients admitted, because now they're in inpatient status. Okay. We have trends. So we could take a look at, and these trends, you could pick whatever trends you want from a standpoint of, what's important to you. But now we have a 12-month trend for the overall average length of stay. So when you look at it here, your light blue is your previous, your current is the dark blue. You see here that in these months, they actually improved their throughput. Ironically, sometimes I think I found the busier we got, the throughput was better. The slower we got, the longer it took, because people kind of were slower about it. You've got all the different, so you've got the different timestamps. ED admits, so everything here, and you can see it all trended in their high season, they kind of came down a little bit. But these are all, again, if I click on the number or the dot, I can click on this, and it's going to open up my analysis, and I can continue to analyze. I also have a compare page. So maybe now we're in our process improvement, and we know that we were looking at different things. So we want to go back and look at ourselves over the last 6 months. And because we started our process now, I'm going to say we want it to end on February, because that's the previous time. That's when we knew the bad stuff was, and the last 6 months we've been doing something different. Now we can see right up front here, if I change my information to my ED provider. Let's start with here. So now I'm looking at my ED average length of stay for this same doctor. In that 6-month period that I'm looking at, we've improved from 306 down to 285. The average length of stay has gone, the average length of stay has gone down. My departure time has gone up. It's kind of stayed in that 6% window, but we probably need to take a look at it and see if there's anything else we can do to improve. So I can begin to look down the, and this here could be, maybe it's the different types of ED. Maybe you have different pods within your ED. You have, the trauma side, the critical care side, and you got the urgent care. You can break those out and begin to see, what area do I need to improve in most? I can do that as well. I can look at I can compare segments. Okay. I realized I've taken all your time up. So Kathy, I guess I'll leave it at this for now. I don't know where to stop.
Great. Thank you, Nora.
Because I can talk for days.
Let's just take one quick question before we leave. And so, Nora, when you use this in the ED, how long did it take you to get it rolled out?
Well, it takes about, it took us about 90 to 120 days just to get agreement on measures. And when I say this, we had a CEO. The critical thing is you have to have senior leadership, and that's involved and really believes in where you're going with this. And we had a new CEO come in and said, any ED docs on here will love this one. She came in and said she's making a bold statement to the community that they will be seen by a provider within 30 minutes of arrival, or she will send them a personal apology and some gift card. So, and she tied that to the physician compensation. And believe me, everybody was like, she's nuts. This isn't going to happen. She's crazy. But she was in every single. She was involved in the interdisciplinary meetings. We went, as I said, we talked. We had lab, we had radiology. Everybody understood their part in the play. And I will say they started out at about 62%, and their goal was to be at 75% for her to not have to worry about it. And I'm happy to say now, and I don't work there anymore, but they still are above the 80 percentile now for patients being seen by a provider within 30 minutes of arrival. Because they did a lot of the other things. They opened up, and they had an area for the patients that were going to be waiting for labs. They did kind of restructure because they had 127 beds in the ER, so they were able to restructure. But it took us about 6 months just to get agreement on the measures, and then probably another 6 months to really get it heavily embedded. But to get the data, it took me. It didn't take me, but because I was already working there, it didn't take me, but maybe 90 days to get the data compiled.
Great. Well, thank you, Nora, and thank you all for joining us today for this webinar. We do have a quick 2-question survey that will launch in your browser once you leave the webinar. I would appreciate if you take a moment to fill that out for us. Enjoy the rest of your day.